Facebook Live lesson. We are coming to you live from the gorgeous, sunny, blue sky environment of Adelaide. And we're around 24, 25 degrees and things are going damn good. Where are you? You can type in where you are and whether you're jealous or whether you're going, nah, 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 nah. Either way. One thing I'd like to begin this session with is this profound quote of, "You won't find a new solution in the same old paradigm," which paraphrased essentially means if you keep doing what you've always done, you'll always get what you always got. So today I want to show you a new technique that I'm not sure if you got taught in university. I sure haven't. I sure didn't, rather, and I can tell you that of the thousands of practitioners that I've worked with in training in manual therapies over the years, very few of them are even aware of this technique. And this technique is going to be on the fibula head. And what we're going to do with the fibula head is use a high velocity technique. And yes, there are different variations. There's the good, the bad, and the Tedley. One of those three. So I'm going to show you a couple of versions today. But when you have a patient and you are considering, well, do I need to, why should I be concerned about the fibula head? I'm a podiatrist. I just deal with feet. Well, as a podiatrist, you would know that there is a body connected to the rest of the most important structure in the body. We're also very aware of the effect that the foot, the ankle has on the whole kinetic chain. So we need to be very cognizant of what the fibula and fibula head in particular is doing. And part of that is just because of the key anatomical structures and connections where we have the ITB and the lateral hamstrings inserting into the fibula head. So there is a direct anatomical effect that takes place there. In the field of fascia and anatomy trains, we have anatomy trains that run from, which are like fascial linings that literally run from the big toe, round the heel, up the calf, connecting with the fibula, hamstrings, and right up to the spine. Oh, look, his mouth is moving. He's talking. You're trying to say something, Scully. Stop disturbing you. Yeah, okay, I understand. Okay. From a clinical clue perspective, the thing to watch out for are, I suppose, a big one is patients complaining of ITB and hamstring troubles. If there are specific tendinous sites around the fibula head, or if there's perineal problems going on, these are also clinical clues. The real clinical test, though, to determine is the fibula head, its articulations and connections, compensatory, or is it causing problems? One of the most effective tests is the neuro-based tests, where you literally apply a compression on the fibula head or a distraction, and these forces that you apply as a clinician will have different effects on the neurological structures, the mechanoreceptors, the pressure sensors. There's a whole range of nerve receptor endings that communicate with the brain, and you can apply these neuro tests and they will either strengthen muscles, weaken muscles, and help confirm for you whether, one, there's a problem that you need to address, and two, how effective your intervention has been. So those details, they're quite involved tests, and you've got to get a few moving parts sorted out. They're the new tests and clinical assessment tests that we'll be doing in our foot mobilisation therapies workshop. We've got level 1, level 2, level 3, all new neuro-based stuff coming to you this year. If you're interested in joining us, the links will be put on this post. If you're already on board, you are in for a sensational time. I am very excited about what's coming up. So excited, it's even gotten Scully lying flat on his back. So if you are joining us, give us a thumbs up, and so your colleagues can go, oh, hey, well, if you're doing that, I better do that too, because it's going to really transform the clinical outcomes you get in your practice for your MSK patients. All right, Scully, so we got anything else to do? What was that? Oh, hamstrings, yes, of course. So we will be looking at muscle strength. Hamstrings, because of their direct connection and insertion into the fibula head, are an important muscle test as well. And so when I talk about hamstring strength, this is the neurological input and effect on the hamstrings versus the actual physical capability of muscle resistance. So that is, thanks Scully, that is one of the crucial tests that will give us some clues as to whether we should be doing this. Okay, so what are we going to cover? Ted's tips. I'll show you my tips in just a moment. But the first one is, if your patient has a history of knee injuries, whether it's acute or chronic, or they've had knee surgery, knee replacements, I would probably recommend, if you're not an experienced manual therapist, is you go through these techniques, do the mobilization, because you have less chance of causing harm. And if you're in a early stage of your career, I'd really be hesitant or cautious about taking on patients or applying manual therapy inputs in patients that if your bank of experience is limited. Okay, so we got Scully here in a supine position. Do you have troubles trying to remember supine and prone? I get a little bit confused. I think it might be because I'm left-handed or dyslexic or a combination of both. Just by supine, a soup bowl, so the shape of a soup bowl, and prone, that's the other way, lying face down. I love Fitzy. Fitzy's reminder of her analogy that she told me. So if you're lying prone, you're prone to being in the arse. So anyway, let's move right along. I'm not sure if that's appropriate for a family program. Okay. So, second tip from Ted is, with the fibula head, you've got to make sure that your surface anatomy is accurate. And with that, what you'll find is that we've got the perineal nerve that runs around the fibula head. It's susceptible. If you don't grip or control effectively, you can cause some irritation there, and you'll generally know that pretty quickly because your patient will be kicking you. And just a clinical tip here, go further posterior than you normally anticipate. So if you, instead of just grabbing hold of the fibula from the lateral aspect, when you're going posterior, really hook in behind. So your fingers will disappear into the flesh. All right. When we have compensations with the fibula head, they're typically in a posterior direction. Reason for that is the bone can't go anterior because of literally if it's going anterior beyond the tibia, it means there's some serious shit that's going on there. So it'll be typically, if it's displaced or compensating, it'll be in a posterior direction. So with our technique, what we're going to be doing is direction of correction, it'll be anterior. Sometimes there's some superior and inferior elements, but that's details we'll go through into in our workshop training for today. The way we're going to do this is we're going to use some mechanical leverage principles. So you can literally just place your whole hand behind the fibula head, and then you take up the tissue tension, and by the time I get into this position, and if the patient has a bit more flesh than Scully's got, there'll be a force applied here onto my contact point on the fibula head, and then it'll be simply take up the tissue tension, and then it's a thrust, hold, release. And what that thrust does is my hand can't go anywhere, and it literally forces the fibula anteriorly, if that makes sense. If the hand's going to be stuck here and I'm going to compress, it means almost a retrograde force will push the fibula head anteriorly. If that makes sense, please give me a thumbs up, because I know sometimes that the words can get lost in translation in the demonstration here. Okay, the reason why I don't like this particular version is because I've got to do all the stabilizing. Yeah, I know, that means I've got to work harder. The knee is able to move forward in the frontal plane, sort of inside, outside, and I've got to control the leg and the distal aspect. And so I've got two moving parts that it takes more effort on my part to control and stabilize that. So my preference is actually to use the patient's body, the table, and gravity to my advantage. And I'll show you how that works. We will, sorry Scully, time for you to wake up. Let us just get you over here. Woo! Woo! Okay, sorry about that. Oh no, now he's gone all bashful. Okay. Straighten him. Oh, don't laugh at him. Poor love. Okay. So, now, just excuse me while I swing over to this side. All right. So, with stabilisation, we've got the femur. I'm going to use that stabilised against the table. I'm going to have gravity work to my advantage, again with stabilising the proximal element. And then this time, my hand is going to be tucked in behind the knee, and I'm going to line up the fibula head with my first metacarpal joint. And so I'll place my metacarpal joint here, and then as I flex the knee, you'll see how the fibula head will be jammed against my hand, and that's the same thing. I can take up the tissue tension and then thrust, hold, release. And that will, again, force the fibula into an anterior direction of correction with a high velocity thrust. Okay, so while that is my preferred method of taking care of the fibula, you've got to take into account, particularly if patients have a history of knee issues. That's one tip to watch out for. But the second is the further you flex the knee, the more the quads are going to tighten up. And sometimes literally the tightness of the quads will just prevent you from getting full flexion. So Ted's tip for getting around that is you need to put something under the hip so that the hip's slightly flexed. When the hip's flexed, it means the hip flexes and the quads are able to flex with less resistance. Does that make sense? If it does, give me a thumbs up, or maybe you just like to send a bit of love my way. Not that I'm missing out on too much love. I've got Dr. Lily behind the other side of the camera sending me plenty of love. All right, so here we are, fibula heads. We've gone through clinical clues, the clinical test to do, the actual actions, end range qualities. And this will be an important thing to take into account. Is it a solid locked end range? Is it a soft leathery sensation? Is it a bouncy soft tissue sensation? Is there fluid interfering with it? All these different end range qualities will influence what you do, how you do, and what the treatment plan and long-term management will be, even short-term management for that matter as well. So, from the studios of Teducation, that's today's lesson. We are going to be running our new foot mobilisation workshops, which include the fibula and the knee, and they'll be happening later this year, 2019. It might be the time for you to do something new. If I could leave you with a primary goal that we're looking forward to doing for you in your future CPD training, and that is literally to blitz your biomechanics. Get your biomechanics, get your MSK skills going so that you can help more people like never before. And speaking of helping more people, tomorrow we have hammer toes and bunions, HAV, coming your way. But you got to get in soon. Early bird is expiring with our mobilisation registrations. That's happening this Sunday, which I think is about 3 or 4 more sleeps on Sunday, March 31st. Make sure you get in before then. Those of you who are joining us tonight for our webinar, it is been basically fully booked. I don't know if there are any spaces left, but it has absolutely rocked the interweb world. So really thrilled about that. It's all about improving orthotic outcomes. So if it's something that you're interested in, what are the clues? Ted's top 3 tips for improving clinical outcomes with webinars by 32%. That's pretty precise, isn't it? You find out why I say that tonight as well. Get yourself registered in. And
with webinars by 32%?
Pardon?
With webinars by 32%?
No, with, did I say with webinars? Jeez, I got to tell you, I'm glad I got a teleprompter here because I cannot believe I said that. Hey, she's my wife. Of course she said that. She's not going to be wrong, is she? All right. Until tonight, until tomorrow, is there one more thing I need to say?
Hello to Case Sinclair.
Sinkers! Well, I hope there's just as much sunshine happening over in Perth as there is here in Adelaide. Nice to hear from you. Glad you've joined us today. All right, I'm all done. Until next time, serve with spirit, consult with care, and help more fibulas today.